Good morning, one and all. Thank you, Samikta. And let's watch this video first. This is a normal eye, the binocular viewing condition showing conjugate eye movement. What does that mean? When the right eye moves upwards, the left eye also moves up. When the right eye goes down, the left eye also goes down. So, in conjugate eye movement, the ocular movements obeys Hering's law. So what is a dissociated deviation? Dissociated deviations are all those deviations which do not follow the laws of ocular motility. So it may be horizontal or vertical, but today we are confining ourselves to the dissociated vertical deviations. I am going to deal with the concept and pathomechanisms. This also comes under a group of conditions called cyclovertical deviations, which include committant hyperdeviation, paralytic vertical deviation, deviations from mechanical factors, cyclodeviations, depression in adduction, elevation in abduction, etc. So the name was, this was first described by Stevenson in 1895. He called it as anaphoria or anatropia. But it was Belchowski in 1938 who gave a comprehensive description of this condition, and he coined the name of DVD. So DVD is classically defined as vertical drifting of one eye when the patient fixates at a target with the other eye. Look at this. We will watch this video. Here the left eye is affected, having DVD. When that eye is covered, there is a drift upwards of that eye, but when the occluder is removed, it comes down. But at the same time, nothing happens in the right eye. So it is against the Hering's law. So no refixation movement of the fellow eye. Dissociation between the movements of the two eyes happen. So it is a dissociated vertical deviation. This picture also shows the same thing. Bilateral DVD, when the covered eye shows vertical deviation, but the other eye remains fixed. So dissociated vertical deviation is said to have three components, that is vertical, horizontal and torsional. Actually, there is a slow updrift which is followed by a comparatively faster downdrift and often associated with excycloversion and exotropia. As a whole, this condition appears to violate Hering's law. But if you consider all movements separately, the vergence and the version components of DVD, each of which will obey Hering's law upon proper identification of the paired muscles involved. There are 5 facts to know about DVD. Fact number 1, it indicates an infantile onset of strabismus. It may be associated with profound sensory anomalies. It's almost always bilateral, though may be asymmetrical. It is more profound in the amblyopic or non-dominant eye, and it may be associated with fusional maldevelopment nystagmus or the latent nystagmus. So what is the demography? DVD is, as I said earlier, is a rare condition and least understood type of strabismus. Most commonly affected age is 2 to 5 years and often associated with infantile or childhood onset of horizontal eso or exotropia, but also can follow surgical corrections of esotropia. It's usually bilateral but may be asymmetric. What is the etiology? It is totally unknown. There are certain speculations made. Few important points to consider include an elastic preponderance of the elevator or the depressor muscles, which imbalances the amount of innervation for each vestibular organ. There may be abnormalities of the visual pathway or imbalance of the binocular stimulation. So let's see what happens in the normal vertical control pathway. Whenever we have to see an upward moving object, the frontal eye field come in action. It triggers the voluntary vertical saccades. Then it goes to the superior colliculus, which coordinate the saccades and orienting. The next center is the rostral interstitial MLF that acts as a burst generator, and that will excite the superior rectus and inferior oblique. Next comes the interstitial nucleus of Cajal, which acts as the integrator and holds the vertical position that will damp the upward vestibular ocular reflex. So the eye remains stable. So then goes to the third nerve and the fourth nerve, and there will be bilateral superior rectus and the inferior oblique innervations. So altogether it happens as a conjugate movement in both eyes, so it obeys Hering's law. And what happens in DVD? Suppose there is no fusion input from the cortex. Suppose we are occluding one eye or there is some sensory inattention. There will be the vestibular nuclei and the interstitial nucleus of Cajal fail to suppress the upward vestibulo-ocular reflex tone. So there will be excessive burst to the superior rectus and inferior oblique of one eye only as induced by the rostral interstitial MLF. So there will be asymmetric innervation. The occluded eye, the superior rectus gets more innervation, and the fixing eye, there will be normal innervation. So there will be slow updrift and excyclotorsion. So this won't happen both eyes in a conjugate manner. So no reciprocal inhibition as well. So it violates Hering's law. What is the pathophysiology of this condition? There are four leading theories. One is the dorsal light reflex theory. Second is the dampening failure or vestibular disinhibition model. And supranuclear subcortical misfiring is the third one. And fourth one is the efferent copy mismatch. Now, let's see one by one. Dorsal light reflex or the vestigial phylogenetic mechanism. This is usually present in some very lower animals with laterally placed eyes like the fish and the rabbits. Let's see what happens in the goldfish. In the upper picture, that is in the segment A, you can see the dorsal light reflex response in the goldfish. The fish is unrestrained. So the degree of body tilt in the roll plane increases with the increasing angles of illumination. But see the B section, it is a restrained goldfish. So the vertical divergence of the eyes increases with the increasing angles of illumination. So this is head tilt, is body tilt is compensated by the vertical divergence of the eye. So is DVD an atavism? What is an atavism? It is a primitive optokinetic response seen in lateral eyed animals. It is present in our body also, but the usual cortex suppresses all atavistic responses, and it manifests when there is this hampering of the binocularity. So when one eye is occluded, as per this theory, reduced nasal retinal stimulation will be there that will trigger upward and movement and extrusion to expose the nasal retina to light. So in DVD, faulty binocular fusion results in disinhibition of this primitive reflex. There are some supporting evidence like DVD worsens in the dim light or occlusion. Second theory is the dampening failure or the vestibular disinhibition model. This is suggested by Dr. David Lee Guyton. This model suggests that the DVD is a compensatory mechanism to damp a latent nystagmus. Nystagmus intensifies when one eye is covered but get dampened as the DVD movement fully developed. So the vertical vergence associated with the DVD helps to dampen the cyclovertical nystagmus. So in nutshell, it says that the vertical vergence component of DVD appears to be a cyclovertical analog of the horizontal convergence that is used by some patients to damp the horizontal component of the late nystagmus. Third theory is the supranuclear theory that says that it is due to some abnormality in the midbrain. It may be near rostral interstitial nucleus of MLF or interstitial nucleus of Cajal. So what is the normal vergence to conjugate? So in DVD, there will be dissociated vertical vergence due to some abnormalities of the midbrain centers. MRI evidence also suggests that in some DVD patients, there will be subtle brainstem asymmetry. And the fourth theory is the efferent copy mismatch that is not very properly understood. the occluded eye receives no fusional feedback. So what happens? The brain sends excessive elevator signal to maintain perceived alignment. That results in slow upward drift and extorsion. Why do DVD patients rarely complain of double vision? Because the central suppression of the image from the deviated eye. So to conclude, DVD is not a simple extraocular muscle dysfunction. The pathomechanism of DVD is still not fully understood. It is a complex supranuclear binocular dysregulation manifesting when the fusion is interrupted. As a whole, it violates Hering's law.